Onc Live Insights is a video editorial program produced by Onc Live.
One feature of neuroendocrine tumors in general and pancreatic neuroendocrine tumors certainly is that they tend to be very vascular. And the fact that they're very vascular has led to interest in looking at angiogenesis inhibitors as a way to treat these tumors. One of those angiogenesis inhibitors was Sunitinib. Sunitinib is a tyrosine kinase inhibitor. It targets the VEGF receptor. So there was some basis to look at Sunitinib as a way of treating patients who have metastatic pancreatic neuroendocrine tumors. Sunitinib was evaluated in a randomized placebo-controlled study. The results of that study were reported in 2011. And based on the results of that study, which showed that Sunitinib is associated with improved progression-free survival, Sunitinib has been used as a standard treatment for patients who have advanced pancreatic neuroendocrine tumors. Sunitinib can definitely be effective in treating these patients. Just as we learned from the randomized study, it can slow tumor growth, and in some cases it can even result in some tumor shrinkage.
The phase 3 trial with Sunitinib also showed significant clinical benefit. The median progression-free survival on the control arm, which is the placebo arm, was 5.5 months, and this was 11.4 months in the treated arm, corresponding to a hazard ratio of 0.42. However, although the p-value is quite small, because of the unplanned interim analysis, the study actually did not achieve statistical significance. Nonetheless, I would say the experts in the field do believe Sunitinib to be an active drug, and it's FDA approved, and it definitely has a role in the management of pancreatic neuroendocrine tumors. In terms of the safety profile of the drug, it's actually a little bit more favorable than what you typically would expect from experience from renal cell carcinoma and other indications. This is because in pancreatic neuroendocrine tumor, the dosing is a little bit different. The dosing is 37.5 milligram continuously, rather than the higher 50 milligram 4 weeks on, 2 weeks off regimen that's used in other indications. Most common adverse events with Sunitinib is hypertension, but fatigue and rash and diarrhea are also prominent things that you may need to manage while the patient is on treatment. So in terms of selecting patients for Sunitinib therapy, certainly this is in the group of patients that has progressive disease. In patients potentially who have contraindications for everolimus, like those who have severe uncontrolled diabetes or hyperglycemia, or has a lot of lung problems where you are really concerned about getting pneumonitis, Sunitinib may be a better treatment to initiate with. For the patients who have problems with recent, for example, thromboembolic events or uncontrolled hypertension or heart failure, Sunitinib would not be my first choice. You have to be a little bit more cautious with those patients.
The choice of Sunitinib versus everolimus, because those are often the two choices that I discuss in patients with relatively slowly progressing tumors, can be quite difficult. In patients with underlying diabetes, I often prefer Sunitinib over everolimus because it doesn't result in exacerbation of hyperglycemia, whereas in patients with pre-existing hypertension or cardiovascular disease, I typically choose everolimus. There may be some indication that tumors that are highly vascular on CT scan or MRI may respond slightly better to an anti-angiogenic drug like Sunitinib, but that really has to be validated. That's more of a hypothesis than something that's really been confirmed.